Hi everybody, it's Dr. Laura Hanson with Connect My Brain. We are in our third season, and this season is focused on neurofeedback. Now that is one of the therapies that we offer at Connect My Brain. And I thought it might be interesting because I do talk about it in previous podcasts. And I thought it would be really good if I took a season and literally identified everything that goes on about neurofeedback and give you some insight why it is such a powerful therapy. And, you don't have to have a problem to do neurofeedback. In fact, probably towards the end of this season, what I'll focus on is neurofeedback and peak performers. But what I thought I would do is to create a conversation about some of the most common reasons people try neurofeedback. And it doesn't necessarily have to be instead of medication, but a lot of people would prefer that, especially with their children, that they are not on medication. But we have kids that come here that are on prescription medications for attention deficit. And the great part about neurofeedback is that neurofeedback actually makes the medication work better. And oftentimes what I find with the parents is that they'll go back to whomever prescribed it and say, hey, listen, we're doing neurofeedback training and we've actually seen some incredible changes. Could we look at reducing the medication and maybe even, in fact, begin weaning off of the medication? I'd like to touch on that for just a minute because one of the things that I think is very important is you have to be very careful with psychotropic drugs and children. Most of them have not, if any of them, have been actually evaluating children under the age of 18. It is not necessarily the population that is tested. It's typically over the age of 18. And there's so much that is going on in children during their development. If you go back to season 2, that's all about child development. And there are windows of opportunity that there's so much change going on. And in fact, as we go through today's topic on attention, I'm going to tie it back to some of the childhood things because after doing this for 26 years, you have to know that I've seen many kids that have been diagnosed or labeled attention deficit or attention deficit hyperactivity. And I can tell you there are some very common things that I've seen in pediatrics that I realize it's not just an issue with attention. And I hope after we go through this material, you'll begin to see that as well. But when I have an opportunity to work with a family, and let's say they do want to get their child off medication, remember I've talked about Connect My Brain is a 3-tier approach. We look at the mechanics, we look at the brain, and we look at the chemistry. And one of the things that I think is so important is that you get a good understanding of what's really going on inside of the body. You balance out all of those things. You get any deficiency brought up. You get anything that's causing inflammation brought down. You balance everything you possibly can. Then I would approach the person that prescribed the medication to then start looking at the child and weaning them. Many times I've seen parents kind of jump the gun and the child just isn't ready because there's so many things going on. It's never just one issue. It's never just one part of our brain or body involved. It is a network. Everything about us is constantly communicating with many different pathways, many different neural circuits, and taking feedback in from the body. So we kind of have to even approach attention deficit or attention hyperactivity in the same way. Today, there's such a controversy around ADHD, and that's the way I'll phrase it for our discussion today. And the reason it is because there are so many children that have been diagnosed ADD or ADHD. In fact, that number has consistently climbed since 1970. And as of 2011, it was 1 in 10 children in the ages of 4 to 17 that have been diagnosed attention deficit. And so here we are in 2022, and I can only imagine what those numbers are. Unfortunately, you don't always see these kinds of reports updated on a regular basis. So for now, that's the information that I have. And then many children, about 1 in 20 to 25, are actually put on prescriptive medications. And they are typically methylphenidate and amphetamines. And the reason that these drugs are used is because they are believed to have a direct impact on a neurotransmitter known as dopamine and another one known as norepinephrine. And what it does is it literally causes an increase down at the synapse. So for my podcast viewers, what I'm doing is actually bringing my fists together, resembling a synapse. And so when we increase the chemistry, we are literally trying to increase the communication from one neuron to another. And so what that's going to do is it's going to, what it's thought to do is that it's going to bring up the ability to pay attention. And so over the years, I've had the opportunity to hear from parents that their child was really not doing well with academics, and they did put them on some medication, and it turned the whole thing around. And, you know, for any of the parents, I can really understand why you would do that, because a child, when they go to school, that's what it's all about, right? They're in school. We want them to do well. So if we can support them with something and enhance their performance, we want to do that. But again, I have to emphasize, we have to realize what these medications are doing, especially to an age population of 4 to 17. So remember what I said in the beginning, most of these psychotropic drugs are not researched or evaluated prior to use in the population under the age of 18. So what I've seen as a provider is a lot of these kids are very skinny and they don't have great appetites. They may even go into being a little hypoglycemic, and that's going to mean that they're going to need to eat on a regular basis. But then if the stimulants are there, their appetite is suppressed. So what are we doing? We're really impacting the use of glucose in the brain, which is ultimately how the brain gets fueled and what needs to happen in order for somebody to have good cognitive abilities or good brain abilities. So to me, it's almost defeating the ultimate goal. So it's just something that we have to look at. And I think if we took a step back, especially during the summertime, this is a golden opportunity. If you have not considered even having Connect My Brain talk to you or see your child, it's summertime. This is where we've got more opportunity for our children to do something different in order to improve either a chronic problem, a suspected problem, and then the next opportunity is going to be when they're back in school and in the fall, the teachers are going to give you an update and say, here's what little Johnny or Judy is doing in the classroom, and you're going to get that message over again. And when you do a developmental assessment, you're able to literally go back and figure out, why can't my child pay attention? You can't have numbers like this, where it's 1 in 10 kids, and call it a genetic problem. That is an impossibility for an epidemic to be a genetic issue. So our next possible thing is it's the wiring, and it's about how our kids are getting wired. And if we look at different events that have gone on since the 1970s and this continued rise, just from being 61 years old, that's me, and looking at where my children were back in the 80s and 90s, even compared to now, and what goes on in our world. We don't have physical education like we used to. We've pulled a lot of music out of our schools. Everything is the potential of a liability to where kids can't play certain either sports or games because there's too much contact. And so then we have the literal, creation of computers and tablets and different types of games, which really do impact the developing brain, just like medication. So before I kind of highlight that point, let's kind of think about now, what are they looking at when it comes to attention deficit? So the early research, that's what it focused on, is that there must be a problem with dopamine. Therefore, let's use some stimulant medication because that will increase dopamine and the individual will perform better. Later research challenged that idea. In 2013, Del Campo, the author of the research, found that in children with ADHD, there was actually decreased gray matter. And that gray matter is where the central nervous system consists primarily of what we call neuronal cell bodies and glia cells. Now, glia cells are really the metabolic master of the brain. It's very important, but they're a very low frequency. I actually love doing low frequency work with neurofeedback because we are influencing the glia cells. And we have a program that's called Squash, and I have seen it over and over again do a marvelous job on an over-aroused brain. So then we looked at they looked at the gray matter in comparison to the white matter. And what they found was that there was decreased gray matter in the brains of an ADHD child or person. Both were given dopamine, meaning those that were considered the control and those that are labeled diagnosed attention deficit. Both groups did better with dopamine. So what does that mean? So it's not isolated that dopamine only works on an ADHD brain, but rather dopamine influences synaptic connection that would improve attention really for anybody. Now, something interesting about the differences between gray matter and white matter, and I want to kind of now step back because what I really hope to show or talk about in this podcast is that, one, we're not really 100% sure of all the finite details of attention deficit, but there are definitely lots of global challenges. And that's one of the things that I have always found in working with children. We may come to the same conclusion, but each and every child, for the most part, has a very unique palette of what is really influencing either attention deficit, seizure activity, depression, inability to have social skills, even the autistic community. And one of the things that is very unique, or let me take that back, that's common in all of those situations, is that there is some issue with the gray and white matter of the brain. So the gray matter is where you process. The white matter is how you get information from one part of the brain to the other. You know, we used to think, excuse me, we used to think that this area does this and this area does that. But now we know it is absolutely a network. I literally will say it's like a spirograph. Do you remember those from, well, I'm definitely showing my age, right? But you'd put your pen in a disc and you'd swirl, swirl, swirl. Then you'd get another disc and you'd swirl, swirl, swirl over it. And before you knew it, the colors were overlapping. And that is my image in my mind's eye of how the communication of the brain actually works. So it isn't hard for me to see that there's all these little unique nuances that go on in all these different populations, but there's similarities. So one of the things that happens when you are a child primarily, and you are in these open windows of development, and you are living on these devices, they're finding through imagery that there is a blast of white matter, meaning that you're getting more white matter. So if I'm trying to communicate from front back or left right or up down, that white matter is literally the tracks that brings this information to all these different places. So if I am getting if I'm getting a blast of this white matter, it's like there's too many trains on the track. And so how can anybody pay attention when there's just an abundance of noise going on? Now, definitely there are many subtypes, and that seems to be the trend, is to create all these subtypes to either ADD or ADHD. And that's my point. It's not just one thing. So it can't be a one-size-fits-all approach. Some of the research says that kids with ADHD actually do far better with stimulants than kids with ADD. So, it is not a one-size-fits-all. So when we look at these different subtypes of what they want to classify as either ADD or ADHD, they could have an increase in frontal activity, meaning like a hypermetabolism, which is going to impact their ability, and they'll actually have an inability to shift attention, and they will over-attend to irrelevant details. Well, that's Lubar from 1999. And then we look at DeVos and Watson, 1991, and what they found was there was a decrease in blood flow. And then we have Costello in 1997 found that there was an issue with the right side of the brain. So there's all these different types of issues going on in the brain. Why? Because we have a unique experience. none of us go through the exact experience while we are in these open windows of development. And that is how your brain is going to get turned on. When you come into this world, you are fully formed, but you are not fully functioning. Think for a minute about a newborn baby. The very first thing that newborn baby does is lift their head. And now their head is literally starting to have an experience in gravity. Now, over the first few weeks, that baby pretty much just sleeps. So there is so much brain growth going on from inside of the womb to the first 3 years of life. We call that neurogenesis. But what they have found in many of these different classifications, not the subtypes, but like in attention deficit as well as in autism, is that there was an issue with pruning, meaning we could have excessive amounts of neurons that are still not communicating the way that they're supposed to. So what you're supposed to go through as you have this experience in the world, you are going to take in your environment. That's going to be the external sensory cues. You're also going to have internal sensory cues, especially from the primitive reflexes, and I'll highlight that in just a minute. But that is your experience. That is your baby's experience. So how could we all have the same experience, right? Because we're all different. We all live differently. We're all in different families. We're all in different parts of the world. So how could you have numbers 1 in 10 globally that are going to have this issue? So we have to think about this experience that a person is going to go through. And that is where I think a lot of the explanation comes from, that one author might find it's a hypermetabolism, another one might find it's a hypo, one might find it's connectivity, the way things communicate, one might find that it is excessive or not enough of gray matter, white matter. So the point is, we can't just stick a global label on someone. We need to figure out the why. Why didn't it happen the way that it's supposed to happen? So I have talked about the Moro reflex, I don't know how many times in these podcasts. You must know by now that's my favorite, and I think it is what I typically will call the enchilada of all reflexes. So let's briefly go through that. So the Moro reflex is the first primitive reflex. It comes on board around the 8th week of pregnancy. Prior to that time are the withdrawal reflexes, meaning that the nervous system is first going to get primed on how to survive. So we must learn how to pull away from something before we learn to go towards something. So typically when we're talking about the brain, we're looking, do we go towards? Do we pull away? Do we facilitate? Do we inhibit? So that's the language that goes on with how the communication goes. So first we learn how to survive. Literally, the baby in the womb is pulling away from everything. What's in there? Amniotic fluid. It's very, there's a lot of vibration, but it's very light. So this is our light touch pathway. Then we go through a transition. That word transition is so important because you have to know how to make a transition in many different situations. If it's hot or cold, so it could be a temperature. It could be getting up in the morning and having a bowl of cornflakes, frosted flakes, and then you have to transition to school. You get the buzz from the frosted flakes, and by an hour in the time that you're in school, you crash, and now you couldn't attend if you want to. You couldn't pay attention if you want to because your chemistry is off. You could have a problem with transition if somebody's going to change the plans on you very quickly and not give you some kind of heads up. I can even see in little people in this office, they need to know, what are we doing now? What are we doing now? What are we doing next? What are we doing next? And that's not staying present. And we literally bring that to their attention and we help them break that pattern. It's very important. That word transition means, do I have the ability to go from one thing to another? And that's not limited to just a place. That's also about the physiology in your body. What chemistry is available? What chemistry is meant to turn off? It's all different kinds of transition. So if your little one or you have issues with transition, that is the beginning thread of looking at Moro. Moro is 3-tier. It is arousal. It is the regulation between carbon dioxide and oxygen. So, how much oxygen do you have in your body? And then it is the onset of the sympathetic nervous system, that fight or flight. So let me highlight what the word arousal really means. So initially, that baby, if it needs something, it's going to become aroused. It's also going to become unaroused so that it will sleep. So arousal is helping to regulate that little physiology. And I want you to really think about some of these examples that I'm trying to give you so that you could possibly go, man, that's in my kid's history. Maybe that's what's really going on, and it's not a lack of amphetamines in your child or a dysregulation to their dopamine, but rather there was something to the wiring that is making this child dysregulated now. Or maybe you're an adult with adult ADD, and you look back in your own history and you can see some of these pieces. So there's a rhythm to this word arousal. Your breath is a rhythm. Your sleep-wake cycle is a rhythm. When you're a newborn, you're sleeping the majority of time. Babies are going to wake up, though, about every 3.5 hours to feed, because glucose is going to leave the brain. They're going to get that chemical, physiological alert. I need glucose. They will wake up, be startled, and they will feed. Now, initially, what we're describing is you are attending to your baby, and your baby is alerting you, I need to be attended to. Now, let's jump ahead to around toddler time, when the child is getting ready to be potty trained. This is like the best example I could ever give anybody. So here's this little toddler sitting on the potty. They have no idea why they're sitting on the potty. You want to train them to be able to go to the bathroom. So you sit them on the potty. Their little pelvis feels the pressure of the potty. You might sit there and sing a song, read a book. You're just there for a few minutes. But as they relax, they tinkle. And then we throw a party. And they, from their mirror neurons, begin to go, wait a minute, something's going on here. They're actually paying attention to your facial expression. So when that child does that, over time, repetition, frequency, that child is associating every single time I go to the potty, we have a party, and it's very exciting. Now, over time, they start to notice there's a little feeling down here in my detrusor muscle where the bladder is. And they're going to begin over time to pay attention to that feeling. And they're connecting the dots inside of their brain. And then all of a sudden one day, they are able to go, I got to go to the potty. Now they're paying attention to themselves. Over time and repetition and other things, certainly. But then they become school age and they go into the school, and now they can pay attention to somebody else. So attention is a developmental sequence. It is not a deficiency in a stimulant medication. Now, again, there is absolutely no judgment. We have to do what we think we need to do. But our children today are really being impacted by either that we're not doing anything or that we're putting them on psychotropic drugs and we're literally changing the communication down at a synaptic level. In fact, some new research is even talking about that those with psychotropic drugs in their history are actually having more memory issues today than ever before. All right, so what are we going to do about this? Well, this is where neurofeedback comes in. Literally, if I do a brain map, I can see if there are more slow waves in that frontal lobe, because the EEG is going to pick up the different bandwidths like theta brainwave, okay? Theta is so important for trying to regulate the neuronal networks. And we're going to talk about the neuronal networks right at the end of the podcast. But again, remember what I was telling you. These are like the spirograph kind of an image. So the theta brainwave, if I have too much of that, no, that doesn't mean that's going to make my networks work better. It's literally going to cause more slow waves, and those networks are not going to be able to communicate like they're supposed to. We can also see hyperactivation in the frontal part of the brain that can be associated to some form of attention deficit. But I can't emphasize enough how important it is to regulate these networks so we can see on the brain map what is going on. Now, we can also see excessive slow waves. Now, theta is considered a slow wave. It has its place. It is a dominant brain wave in children, but it, like anything else, we're meant to be in balance. But we can also see excessive slow waves in concussion and traumatic brain injury. So again, slow waves are not unique to the diagnosis, but rather unique to the individual and their personal history. So theta brain waves are very much associated with volitional movement, like movement you would do at will. And it's also associated with being offline, like daydreaming, okay? And it's also associated with inattention and internalized thought, like being overly focused on self, okay? So every brainwave has its uniqueness on what it is regulating inside of the brain. Now, alpha, let me kind of focus on alpha for just a second. Alpha is our place of idle. And what happens, especially when we close our eyes, alpha goes way up. Let me bring in something, make sure that I'm clarifying. There is a progression to our brain waves. So delta is our sleep wave. Before we could get to delta, we have to be in theta. But theta is not just about sleep, but it is associated. So we can have volitional movement, we can have internalized thought. Now, some internalized thought is okay. Excessive internalized thought would be the imbalance. Then prior to theta is alpha. And then after alpha is low beta, then high beta, then gamma. So they're all based on their frequency number. Delta is 1 to 3 hertz, theta is 4 to 7, alpha is 8 to 12, low beta is 13 to 15, and so on. So it's a progression. And they each have some unique dynamic roles. So theta, volitional movement, imagination, internalized thought prior to sleep. Alpha is your ability to sit still. One of the most mature forms of movement is the ability to sit still. So alpha, you close your eyes, alpha's in the back of the brain, it goes up. And especially when you intend to sit still, we get this incredible relaxation to the brain. And, this is one of the things, especially I see with kids, and parents will report, could you just tell my child how important it is to be still? And it is. But a lot of kids have issues with being still, and it's not necessarily hyperactivity. This is why it's so important to understand development. So some kids, because there is too much of a dampening effect going on in their brain, they literally keep themselves moving to keep themselves up. That is a totally different thing, and you wouldn't know it unless you did a developmental assessment on your child, right? So if we have an issue, because theta and alpha are very close together, right? And sometimes when we don't use one over the other, sometimes they start to blend. And if we have an issue that alpha isn't able to be blocked, so what does that mean? That means when I am paying attention, it could be visual, it could be auditory, it could be tactile, it could be a cognitive stimulus, it could be anything. If I'm supposed to be paying attention to something, alpha should be blocked, meaning alpha goes down. But if alpha is staying up, then that too can keep that brain in a state of not being able to pay attention. So it's never just one thing. That's the most important part of what I wanted to share with you in this podcast. So the networks that are involved when it comes to the ability of the brain to pay attention, where as I got wired up, these networks would have started communicating. And there are 3 of them in particular. One is called the default mode network. This is when you are really just allowing your brain to wander. And, we need to do that. We don't need to keep these kids going all the time. Sometimes they need to be left alone, not like you leave the house, but they need to be on their own to create their own enjoyment, not a tablet, not organized sports and events. Sometimes they just need to figure it out for themselves. If they never have an opportunity to figure it out themselves, they won't automatically learn how to do that. Why? Because this is their experience. So what is their experience? Are they going? Or do they get a chance to allow themselves to just wonder, inactivity? Let me think about what I can do. Now, what they have found in attention deficit is that usually there is some atypical connectivity. Now, we don't know exactly what that atypical, but it's just that it's not connecting the way it's supposed to. And that would explain why it's very easy for them to become distracted. Now, I can also tell you, if your withdrawal reflexes are still very high, you are very easily distracted because it's like all the hair on your body is constantly standing up. This hair on our body became our first defense. And this is why you could get so close to somebody and you may feel it and you may pull yourself away because you're not comfortable being that close. Remember what I told you, the very first system that got wired up is your survival system. And that survival system, if it's taken over for an abundance of reasons, you are very distracted because any light that comes in your peripheral vision, you're on it. Anything you hear, anything you smell, anything will distract you because you're trying to make sure you're safe. Again, it's never just one thing. Now, we also have what's called the attention and the cognitive control network. This is typically considered to have lower activity in the population that's struggling with attention. I think that makes sense. Now, when the default mode network dampens, that's when your attention and cognitive control network is supposed to come up, and vice versa. So they're going to be in this kind of reciprocal relationship. Then we have the reward system. This is where we get our motivated behavior, anticipation and reinforced behavior. ADHD kids may overestimate short-term rewards for long-term goals that will affect their ability to plan and make decisions. This is directly a dopamine pathway. So the big picture idea is there are so many reasons why somebody may have an attention issue. Research has even been able to validate, yes, being on a stimulant medication increases the dopamine pathway. Again, motivated behavior, reinforced behavior. But that happened whether you were diagnosed, labeled, suspected attention deficit at some level. So meaning that would do that for anybody. When we think about development, there are very specific things that are looking at attention, and that is a wiring process. And we each have a very unique experience, and we can be wired differently than the one sitting next to us. We look at a different type of therapy like neurofeedback. So we can literally measure, where are those brain waves? How are they robust? Are they under power? Is it unorganized? Then we can offer neurofeedback therapy. Now, just think about this for a minute and then I'll wrap it up. When you're sitting and doing neurofeedback, you're sitting in a chair, you have a cap on your head, we have a certain program set up for you, like Focus. They're going to sit there. They're actually going to either do a 20-minute or a 30-minute program. They're watching something on Netflix or Disney. And then there's a filter that's brought over the screen. When they're in the correct pathway or they're in the correct program, the picture will become very bright. They will also hear some kind of a sound. And that sound will then become connected to the brightness on the screen. They don't even have to pay attention to it because the subconscious mind is picking it up. And the subconscious mind is where patterns are laid down. So during this 20 to 30 minute session, the child is in, or the adult is in a seat, and they're sitting still. And alpha is promoting relaxation, and the brain is getting a chance to exercise its normal, expected pattern. This is one of the safest ways that we can approach anybody struggling with an attention issue. Thanks so much for joining today. I know this was a lot of information, but the cool part is you can always go back and listen to it again. If you would like to call us at the office and maybe just talk about the situation either you're going through or your child's going through, please give us a call and we'll schedule a time to chat. Our office number is 678-501-5172. Be sure and visit our podcast page on the website, connectmybrain.com. There's a few freebies on there and a survey. We'd love your feedback about what is it that you would like to know about your marvelous brain. I enjoy spending my time with you. I thank my podcast manager. She has just brought my podcast to such an incredible level that I'm so excited about being able to get this information out there, as well as it is just presented on such a professional level. So thanks, Marcy. Make sure you subscribe and make sure you share us with your friends. Have a great day.